So let's look at the administration of magnesium sulfate in preeclampsia. So the purpose is to prevent or control convulsions in preeclampsia or eclampsia. It acts by depressing central nervous system irritability and blocking neuromuscular transmission. So we have a standard regimen, and the commonly used is Pritchard's regimen. You begin with a loading dose, which you give 4 grams of 20% magnesium sulfate solution intravenously slowly over 5 to 10 minutes, plus 10 grams of 50% magnesium sulfate intramuscularly, 5 grams deep into each buttock. Use a separate syringe for each side. Mix with 1 ml of 2% lignocaine to reduce pain because the injection is highly painful. Total loading dose is 14 grams, 4 grams IV plus 10 grams IM. Next is the maintenance dose. Here you give 5 grams of 50% magnesium sulfate intramuscularly every 4 hours into alternate buttocks. Continue for 24 hours after delivery or after the last convulsion, whichever is later, whether is the delivery that happened last or the woman delivered and convulsed later. So the third is monitoring during treatment. Magnesium sulfate can be toxic, so careful monitoring is essential. So you check for patellar reflex, test before each dose, check if the reflex is present. You check for respiratory rate, count respiratory rate per minute, check if it is greater than or equal to 16 breaths per minute, that's the minimum requirement. Urine output, you measure hourly, check if it is greater or equal to 30 ml per hour, shouldn't be less than that. If any of these are absent, stop magnesium sulfate immediately and check serum levels. So what's the antidote for magnesium toxicity? If signs of toxicity appears, such as absent reflexes, shallow breathing, urine output is decreased, give 10 ml of 10% calcium gluconate intravenously, slowly over 10 minutes. Alternatively, you can do Zuspan regimen, which is intravenous only. Here the loading dose is 4 grams magnesium sulfate intravenously over 5 to 10 minutes. The maintenance is 1 grams hourly intravenous infusion for 24 hours. This is used where infusion pumps and close monitoring are available. So what are the key precautions to take note? Avoid magnesium sulfate in renal failure or oliguria, that's reduced urine output. Monitor mother's vital signs and filter heart rate continuously. Continue monitoring 24 hours postpartum. So you continue monitoring for 24 hours after birth. So in summary, the loading dose is 4 grams IV plus 10 grams IM. You give once. You start immediately after pregnancy or the last convulsion. The maintenance dose is 5 grams IM. You give every 4 hours on alternate or different buttocks. The duration for the maintenance dose is 24 hours after delivery or last seizure. The antidote is calcium gluconate, 10 ml of 10% given intravenously. You give once if toxicity occurs and you give slowly. Thanks for listening.